Welcome to this presentation on the effects of manual therapy in the management of low back pain in the pregnant population. Low back pain affects about 45% of pregnant women. The exact cause is unknown. Degenerative mechanical and hormonal changes are believed to contribute. The hormone relaxin is one of the proposed underlying mechanisms for pregnancy-related low back pain. Released throughout pregnancy in varying amounts depending on the woman, it softens the connective tissues, produces ligament laxity, and softens pubic symphysis, which can possibly lead to pain and decreased pelvic function. Signs and symptoms include pain in the low back, luteal region, pubic symphysis, and sometimes in the lower extremity. A change in the center of gravity occurs with an increased anterior pelvic tilt. There can also be a leg length discrepancy. Risk factors for a woman developing low back pain include strenuous work, history of low back pain, or previous trauma to the pelvis.
The three diagnostic factors are screening for red flags and psychosocial factors, differentiating between pelvic girdle pain versus pregnancy-related low back pain, and assessing disability. There are several things to keep in mind when screening for red flags, such as history of cancer, recent trauma, immunosuppressed condition, and bowel and bladder changes. These are some of the conditions that can also present as low back pain. Pelvic girdle pain presents in the PSIS, gluteal region, post-thigh, and groin area. Pregnancy-related low back pain presents in the lumbar region above the sacrum. Throughout our research, the literature highlighted the following tests: Gainsland's test, POSH, and active SLR as special tests that could rule in pelvic girdle pain. Many of these tests are performed in supine, but due to the short duration of the special test, the fetal circulation is not compromised. Five tests were performed in the Cook et al. 2007 study to rule in pelvic girdle pain. Of those five, ASLR, thigh thrust, or POSH, Gainsland all showed high specificity, low sensitivity, and could rule in pelvic girdle pain. The following two questionnaires were used to assess disability in the pregnant and postpartum population.
Usually, pregnancy-related low back pain is self-limiting, resolving in the weeks to months following delivery, but the following are risk factors for developing long-term pelvic girdle pain: back pain before pregnancy, prolonged labor, several positive pain provocation tests, onset of pain early in pregnancy, and not losing weight after delivery. It has been shown that the patient's degree of difficulty in performing the active straight leg is associated with the level of pain and disability. Those patients that have only low back pain with no pelvic girdle involvement tend to do better than patients with complete pelvic girdle pain.
The use of manual therapy for women with pregnancy-related low back pain has been researched, but there is limited evidence suggesting its clinical usage. Current literature suggests that manual therapy might be effective. Manual therapy may therefore benefit women with pregnancy-related low back pain who are having an otherwise normal pregnancy. In regards to interventions, the first interventions that we found to be beneficial was muscle energy techniques. In 2005, Cleland et al. Proposed muscle energy techniques as an effective manual intervention in two case reports. Muscle energy technique is a manual technique directed at correcting sacral and pelvic positional faults from connective tissue softening and ligament laxity. METs were combined with therapeutic exercises in this study. How are METs used in these studies? Muscle energy techniques were used to address anterior and posterior pelvic rotation, decrease inflare of the pelvis, decrease sacral torsion, and address sacral extension. although we would like to acknowledge that this study was a low-level evidence because it was a two-case series. Hence, this study should be considered as an emergent evidence. The next evidence that we found to be effective in the management of pregnancy-related low back pain is the use of spinal manipulation therapy. This is a manual technique that utilizes localized force of HVLA. In 2009, Corson et al. Did a literature review evaluating the effectiveness of spinal manipulation therapy, and what they found out was that most reports actually suggest that manipulation may decrease pain, increase mobility in the pregnant population. So, in conclusion from that study, since effective treatments for pregnancy-related low back pain are limited, clinicians may want to consider SMTs as a treatment option if no contraindications are present.
This study, done by Murphy et al. In 2009, used a diagnosis-based decision rule consisting of 3 stages to treat 78 women with pregnancy-related low back pain. Stage 1 involved screening for red flags. Stage 2 involved placing the patients in treatment categories with corresponding matched interventions. Stage 3 looked at factors that could perpetuate the pain experience with matched interventions. The most commonly used technique was a high-velocity, low-amplitude manipulation performed with the patient in sideline. An alternative position was an oscillatory mobilization with the patient in prone. Some form of manual therapy was performed on all but 10 subjects at each treatment session. The end-of-treatment results showed that 73% rated their improvement as excellent or good, and there was a clinically significant improvement in pain in 63.5%. There was even better improvements at the 11-month follow-up. An RCT is needed to further investigate the use of the diagnosis-based decision rule, as well as the effectiveness of manual therapy. In regards to risk and harm resulting from manual therapy, a 2012 systematic review found only 7 reports of adverse effects of manual therapy in the pregnant population. This suggests that infant complications from manual therapy are rare and infrequent.
Regarding exercise for this population, the best current research is the RCT by Stooge et al. In 2004. 81 subjects were randomized into a control group and a specific stabilizing exercise group and were assessed at baseline, after intervention, and at 1 year postpartum. The control group received patient education, ergonomic advice, strengthening, stretching, and joint mobilizations. The specific stabilizing exercise group received all of these treatments, plus motor control training of the deep postural muscles. The specific stabilizing exercise group had clinically and significantly better improvements in pain, disability, and health-related quality of life after the intervention, and these results were maintained at 1 year postpartum. Similarly to the Cleland study, manual therapy was combined with exercise.
Clinical bottom line. The current research regarding the management of pregnancy-related low back pain indicates limited evidence suggesting that spinal manipulation may reduce pain and disability, emerging evidence suggesting that the use of METs combined with therapeutic exercise may be an effective treatment approach, and moderate evidence supporting the use of stabilization exercises.
Okay, that concludes our presentation on the management of pregnancy-related low back pain and the role of manual therapy. Here's a list of our references. Have a good day.